This is important for all of us. Sorry, this is important for all of us, and both of us in reconstruction and all other urologists. And because the issue of urethral stricture, apart from the volume of cases we manage in all our centers, the management keeps on evolving. The management of urethral stricture 10 years ago is different from management of the same condition disease. So it's something that is evolving, and because it's evolving, we need to constantly update ourselves on this important topic. And it requires a good understanding of anatomy, basic principles of reconstruction and plastic surgery, tissue handling, and it is apt that today we're discussing this important topic. So I want to start by inviting the speakers to speak. I think maybe all other speeches will be after. So we have 6 speakers. The first one is Dr. C.M. Anyazi. Dr. Anyazi is a consultant urologic surgeon, special grade 1, Federal Medical Center, Wari. He will speak on introduction and epidemiology of urethral stricture for 10 minutes. Then the next will be Dr. Efiok Esiet, a consultant urologist, Department of Surgery, University of Uyo Teaching Hospital, who will speak on surgical anatomy of the urethra for 10 minutes only. Then the etiopathogenesis will be discussed by Dr. Anyadike Chinedu, a urologist at Lagoon Hospital, Lagos, and he will speak for also 10 minutes. Then clinical evaluation and diagnosis by Dr. Isaac Lawal. Dr. Lawal is a consultant urologist, National Hospital, Abuja. He will speak for 15 minutes. Then that will be followed by Professor Habib Tijani, Professor of Surgery and consultant urologist, University of Lagos and Teaching Hospital, who will speak on treatment and follow-up for 25 minutes. Then we have complications of treatment and their prevention by Associate Prof. Taylor of the Department of Surgery, Division of Urology, University of Maiduguri, Teaching Hospital. Then we have 15 minutes of questions, discussions, questions and answers that I will moderate together with Professor Ekeke. Professor Ekeke is the host and is Deputy Provost, College of Health Sciences, University of Port Harcourt. So we can start, and we keep the time. We'll try as much as possible to keep time. 2 minutes to expiry of your time, we'll have warning. So we start with Dr. Anyazi on introduction, epidemiology of urethral stricture. Dr. Anyazi. Share your screen and start. Make it on slideshow. Expand it to slideshow.
Yes.
Yes. Yeah,
Good evening. Good evening, Mr. Chairman. Good evening, the moderator. Good evening, my fellow speakers and the housekeeper. Good evening, colleagues. My topic is Introduction and Epidemiology of Urethral Stricture. I have been introduced already. I have no disclosures to make. Urethral stricture is the abnormal narrowing of the lumen of any segment of the urethra surrounded by corpus spongiosum. Strictures can cause voiding difficulties often and then affect the quality of life of the sufferer. It's a disease of antiquity. The first recorded attempt was at the 6th century BC in India. Since then, there have been evolving efforts in the management of urethral strictures. Urethral strictures have been treated variously by dilatation, which many of us do, internal urethrotomy, external urethrotomy, urethroplasty, which is a superior treatment modality, but very difficult to do, stenting, which is not common in our environment and the use of urethral as in DVIC. It is worthy to mention some eminent urologists who pioneered the works in the evolution of the current management of urethral stricture. They include Johansen, who popularized the reconstruction of the urethra in the 50s. Devine and colleagues reported the use of full thickness skin graft in 1963. Blondie et al. Did a lot of work with scrotal flaps in long strictures. Orandi A made one-stage urethroplasty attractive when he published his experience in 1968. Turner Warwick was at the forefront in the management of traumatic posterior urethral strictures. J.K.M. Kwati, working in Ghana, developed and popularized the use of versatile penile prepucial island flap urethroplasty that transformed the management of urethral stricture disease in West African sub-region. Webster and colleagues provided the insight that enhanced the skill in the technique of perineal transpubic repair of post-traumatic prostatomembranous urethral strictures. Jack McAninch popularized the use of circular facial cutaneous penile flap. Working with other colleagues as Jordan, Chapel, Christopher, and others, they refined the technique of excision and primary anastomosis. The introduction of buccal mucosal graft in urethral stricture treatment has been greeted with enthusiasm globally. It is considered the most appropriate tissue for augmentation and substitution urethroplasty. Babagli, Asopa, and Kokani have popularized dorsal onlay grafts for anterior urethral strictures. Non-transecting bulbar urethroplasty is gaining attention because it spares the bulbar arteries. Attention to surgical principles, guidelines, and teamwork contributed to the current improved clinical outcomes in the management of this condition. Recent advances in the treatment of urethral stricture has emerged from researches on regenerative medicine and nanofat regenerative surgery. Epidemiology. Incidence is not clearly known, but estimated at about 0.6% among susceptible people in the United States of America, especially the elderly. At the Federal Medical Center, where a new registrations from January 2017 to 31st December 2021 was 13. At a private hospital in Owerri that focuses on urology, 33 new cases were recorded within the same period. Ata, CA, and et al. Studied 150 cases over 7-year period at Enugu. Tijani KH et al. In Lagos studied 84 cases over 8 years. And Ahmed et al. In Zaria studied 556 cases over 9 years. It appears this condition is more common in northern Nigeria. Or outpatient visits are frequent among these patients as they are prone to urinary tract infections, urinary retention, chronic kidney disease, and urinary incontinence. In the United States, Blacks are at a higher risk of urethral stricture than whites. Urethral strictures occur more in the anterior urethra, about 92.2%, with predilection in the bulbar urethra, where it affects more of younger patients. The mean age of urethral stricture presentation in Italy was 45.1 years, range 2 to 84 years. In Lagos, Nigeria, the mean age was 43.1 years, while the range from Zaria was 9 to 80 years, mean at 40 plus or minus 12.9 standard deviation. The mean age of presentation was similar to studies in India and the United States of America. Etiology of urethral strictures can be classified broadly into iatrogenic, traumatic, inflammatory, infection, idiopathic, and congenital. Worldwide, iatrogenic and idiopathic causes are the commonest, comprising 33% each in one meta-analysis. In sub-Saharan Africa, most of the papers coming from here, about 30 of them in number, the commonest cause is infective urethritis, more in less developed series, followed by trauma. In Nigeria, urethral catheterization is the commonest iatrogenic cause, according to the work done in Lagos. Changing from latex to all silicone catheter has reduced the incidence of urethral stricture. Recurrence is common with DVIU and urethral dilatation. Posterior urethral disruption injuries are cosmopolitan and commonly associated with pelvic fractures. Post-infectious urethral stricture due to gonococcal urethritis are currently rare in the developed world, but common in developing countries. This disease has a negative economic impact. The cost implication of treating urethral stricture in Nigeria ranges from 250,000 to 2.5 million naira, depending on the type, the hospital, the city, and the attending surgeon. In Abuja and Lagos, it costs more to treat urethral strictures. In the United States of America, the average estimate for treatment per patient per year is about $6,000 US. Our patients are for minimum wage at 30,000 naira only, and majority of them pay 70% out of pocket expenditure for medical care. Conclusion: urethral stricture is really common in urological practice. Its etiology varies geographically and according to socio-economic class. Post-infectious urethral stricture has decreased in the developed countries, while we encounter them often in West African sub-region. Health education, prompt treatment of urethritis, especially from sexually transmitted diseases, and the use of quality or silicone urethral catheters may reduce the incidence of this condition. It is important to identify the factors that will reduce the iatrogenic causes. Thank you.
Thank you very much, Dr. Anezi, for keeping to time and also giving us a very good introduction on this topic. So, questions, comments after all the presentations.
At the end.
Yes, at the end. That's what I want to see, that at the end, so that people will keep their questions to the end.
Through the
so
chat
we'll
box.
So, pardon?
Through the chat box, they should send their questions.
All right, okay, then they can start sending the questions?
Yes, I will
read it. Fine. So
can I stop sharing?
Yes, stop sharing, and so that we take the next presentation by Dr. Ifyok Esed on surgical anatomy of the urethra. Dr. Esed.
Has no message.
See,
do we minimize it?
Okay.
Someone else is sharing.
All right, go ahead.
Yeah, good evening, senior colleagues and colleagues. My name is Dr. Ifyok Esed, consultant urologist with the Teaching Hospital, University of Uyo. I will be talking on the surgical anatomy of the urethral stricture. In looking at this stricture, this topic, I will go through the outline here: introduction, embryology, gross anatomy, blood supply, nerve supply, and then the conclusion. By way of introduction, the urethra is a fibromuscular tube that conducts urine and semen from the bladder and the ejaculatory duct, respectively, to the exterior. It is part of the urinary and genitourinary system in female and male, respectively. A good understanding of the anatomy is key to successful urethral surgery and reconstruction. Looking at embryology, the urethra forms from the urogenital sinus. The sinus itself is a derivative of the cloaca. The spondyurethra is formed after about 7 weeks by tuberalization of urethral fold along the urethral groove. But the most distal portion of the male urethra usually formed by invagination of the epithelial tract at the distal end of the urethral tubercle. In terms of the embryology still, this is just the diagram of the embryo, highlighting the cloaca, which is usually the terminal end of the hindgut. Also emptied into the cloaca is the allantois. The same picture showing the division of the cloaca anorectal canal into the anterior part, which is the urogenital sinus, and the posterior anorectal region. This showing the urogenital sinus is composition of the vesical, pubic, and the phallic part. The external genitalia, the embryo, remember the urethral fold here, the genital tubercle, eventually a lengthening of the genital tubercle to form the phallus, and then the invagination of the epidural tract to form the distal urethra. Same picture here, and then it's worth noting that in the female, the whole female urethra developed from the vesical part of the urogenital sinus, while both the pelvic and the phallic component portion of the urogenital sinus from the vestibule and the lower two-thirds of the vagina. Looking at its gross anatomy and the histology, the urethra usually divided into two segments, the posterior and the anterior urethra. The posterior urethra, generally the urethra measures about 20 to 25 centimeter in male and about 4 cm in the female. The posterior urethra comprises the pre-prostatic, prostatic, the membranous, measuring 2 by 2, 2 and 2 to 5, 2.5 cm respectively, while the anterior urethra measures 3 to 4 cm, and then the penile urethra and the spongy urethra measures, penile or spongy urethra is about 15 cm in length. Like I said, the urethra usually originates from the bladder neck, traverses the prostate eccentrically, turns at anteriorly at about 35 degrees, midpoint of the prostate, and then continue retropubically through the prostate to exit at its apex. Usually the urethral angle, the way it turns 35 degrees, the dividing line between the pre-prostatic urethra, which is proximal, and the prostatic urethra, which is the distal part of it. The posterior wall contains the urethral crest, which the highest point on that urethral crest is the verumontanum, which is a landmark in TURP. And the opening of the prostatic utricle is at the summit there, on either side of at the summit. Beside the summit are the opening of the ejaculatory duct. The pituitary lining is predominantly transitional cell. And then the prostatic urethra is surrounded by inner circular and outer longitudinal muscle. This is the reverse of what happened in female urethra. This is the picture of the urethra traversing the prostate, traversing the urogenital diaphragm as a membranous urethra, traversing the bulk of the penis, and then the spongy urethra at the tip of the, continues to the tip of the glans penis. So this is a cross-section, the same thing as we described. In female, this is section of the coronal section of the female urethra. Like I said, is 4 cm. It has the internal sphincter there and external sphincter, which are striated. The muscles, the surrounding muscles are circular small muscle at the inside, and then the longitudinal small muscle at the outward part of it. Of course, this external in the female, this what look the external, the opening of the urethral meatus, which is at the vestibule of the vestibule, and with the introitus posterior to it and the clitoris anterior to it. The membranous urethra, like I have described, is shortest, the least dilatable portion. Usually the type that are involved, the section that are usually involved with trauma, involve the pelvic fracture. It's invested in the urethral sphincter as it transverses the urogenital diaphragm. It's fixed to the pubic rami and the inferior pubic rami and the ischial rami. It's lined by pseudo-stratified or stratified columnar epithelium. It has very rich vascular submucosa that allows for better healing. The bulbar urethra itself, like I said, traverses the bulb of the penis. It receives the corpus gland, the bulbar urethral gland, which arises from the membranous urethra but drains into the bulbar urethra. The pendulous urethra traverses the corpus spongiosum down to the tip of the penis. The distal urethra lies in the distal urethra. We have the fossa area of dilatation, fossa navicularis, and then if you have a cross section of the spongy urethra, after the epithelium is the lamina propria, which is made of the fibroconnective tissue with elastic fibers and scattered longitudinal rented model. This makes it a very expandable tissue, makes it the urethra, the anterior urethra. The bulbar and the spongy urethra, the epithelial lining is stratified pseudo-columnar. Stratified or stratified columnar epithelium. The distal urethra is lined by the non-keratinizing squamous epithelium. This is a cross-section of the urethra. It's important in describing this cross-section. Shows the urethra here, and then the covering of the urethra is the same as the covering of the penis. It is important to know the layers that cover the urethra, which is the same layer cover the penis. The skin, the datos, the bulb fascia. Usually it's important because when you talk about reconstructive surgery, as it pertains to substitutional urethroplasty, it is the datos fascia here that serves as the blood supply to the penis lies on the datos fascia. You know, it's from external, superficial external pudendal artery. So they lie here, the blood vessels, nerves, and veins lies on this. And then the plane of dissection usually is a vascular plane between the skin and the datos, and between the datos and the bulb fascia. The skin slides, the bulb fascia slides freely. The datos fascia slides freely on the bulb fascia. So those are the planes when you are trying to develop a cutaneous pedicle penile skin flap. It is the datos that is serves as a pedicle for whatever reconstruction you want to make. The blood supply to the urethra is basically depend on the site. The posterior urethra is supplied by the inferior vesical vessel, that's the prostatic and membranous urethra, while the anterior urethra derives its blood supply from the common penile artery, which usually divide into the bulbar artery that supply the bulb of the penis, and then the circumferential cavernosal arteries, which supply the urethra in entire the corpus spongiosum. And then we also have the dorsal penile artery, ends up with the dorsal penile artery after giving us the circular central cavernosal supply that supply the corpus cavernosa. So the dorsal penile artery goes down. It usually goes down to supply the entire penis, giving us circumflex arteries along its path that supply the corpora cavernosa and end in the corpora spongiosum, ends in the glans penis, and then retrogradely supply the corpus spongiosum again. So the urethra actually has a bipedal blood supply. This allows for reconstruction of the urethra in terms of anastomotic urethroplasty. So you can divide the urethra, the stricture in an anastomotic prelim. But we must remember that when you are mobilizing, I know sometimes they need to mobilize the bulb of the penis and the intercrural space to gain the length of the urethra, the bulbar urethra. You must be careful. The artery that is usually damaged is the bulbar urethra. You must make sure this is preserved, otherwise your repair will fail. This in terms of shows the bipedal blood supply that we have described, having from the proximally and distally, so you can divide the urethra and do your anastomotic urethroplasty. The lymphatic drainage from the prostatic and bulbar membranous urethra is to the obturator and external iliac lymph nodes. The penile urethra on its own drains into superficial group of lymph nodes. The nerve supply to the urethra is basically from the dorsal nerves of the penis, which arises from the sciatic nerve, all the way from the sciatic nerve. And they also receive branches from the perineal nerves. In terms of, so in conclusion, one would want to say that the urethra is a highly vascularized but delicate structure that allows for very good healing when you are doing your repairs. But adequate knowledge of the anatomy and preservation of its blood supply are indispensable for successful surgical outcome. Thank you.
Thank you very much, Dr. Efiop, for also keeping to time just barely. So we take the next, and that is Dr. Anyadike Chinedu. Dr. Chinedu, get set to give us your presentation on etiopathogenesis of urethral stricture. Dr. Chinedu.
Yes, sir.
First slide.
Okay, I want to share screen.
Go ahead.
Fine. Okay.
Okay, thank you. My name is, yes, sir, Dr. Anyadike. Standing on all existing protocols, I will be discussing the etiopathogenesis of urethral stricture disease. Okay, I can't move my slides for whatever reason.
No, just put it there and put enter. The thing will go back to, the thing has moved from where you were because you were on internet. Just click in the middle and then it will move.
Okay.
Okay.
Okay, thank you, sir. Now, urethral stricture is a fibrotic process with various degrees of spongiofibrosis that results in a poorly compliant tissue and decreased urethral lumen caliber. It's a very common condition in our environment, as the previous speakers have said and noted. And it's one that usually doesn't become symptomatic until the lumen is really constricted. I mean, it is the narrowing of the urethra that causes obstructive symptoms. They can be divided into 4 major groups: inflammatory, idiopathic, iatrogenic, and traumatic. The frequency of etiology is widely related to the area of practice, has been changing over time, but still a function of the location and the level of practice, if I may use those words to say so. I will say that in Nigeria, from the early 80s, when Atta and Bono and Anikwe Senior reviewed 150 patients in Enugu, they found infection to be responsible for 65.3% of cases and trauma in 34.6. I must also note here that a lot of work has been done as regards urethral stricture in Nigeria, and it is quite impressive. In 1998, Ahmed and Kalawi in Zaria reviewed 556 males and found infection to occur, the infectious etiology to occur in 66.5% of patients and trauma in 31.7%. Ogwike in 2006 in Benin reviewed 42 patients and found the traumatic etiology to account for about 55.9% of patients against iatrogenic in 8% of patients. In Nnewi, Nwafo and Ugezu reviewed 62 patients and found infection to cause 48.5% of these cases, as against trauma of 51.6%. Ekeke and Amuson did the same study, the same type of study in 2002, and found trauma to be the leading cause of urethral strictures in Port Harcourt. Tijani and Adesanya in Lagos reviewed 84 patients and found trauma to account for 72.3% of cases. They had a higher incidence of iatrogenic causes, 20.5 as against infection. So the issue is what really is the most common cause of urethral strictures in our environment. In the last 2 years, recent studies, Oyewolo and Ahmed in Zaria found trauma to account for 33.3% of patients. Abubakar and Dogo in Yobe found still infection to account for almost 60.8% of patients who had urethral strictures. So the question is, what's you find that the etiological factor is a function of the location of the practice, and that can be expatiated. Slides are not moving again.
Click in the middle. Tap it.
Okay. No, so historically, inflammatory etiology, Neisseria gonorrhea and non-gonococcal urethritis has always been the organism that everybody has sat on and said gonorrhea causes urethral strictures. Over time, whether chlamydia trachomatis or other Yersinia gonorrhea causes urethral strictures has been at best controversial. Lichen sclerosus, balanitis, xerotica obliterans is one condition that is known to affect the genital region and is known to cause a panurethritis, especially where it occurs. Iatrogenic etiology can be divided into 5 causes. Transurethral resections, prolonged catheterization, cystoscopies, and hypospadias repair. I must mention that in our environment, the most common cause of iatrogenic related urethral stricture is catheterization. Not necessarily from prolonged catheterization, but from quality of the catheters that are used, that they're using larger size catheters in smaller urethras and every other small thing that comes with it. Having said that, prostatectomy in our environment causing urethral strictures is not so common, but it's usually following radical prostatectomies and post-prostatectomy strictures. Of course, this must be mentioned, trauma in our environment and urethral strictures. Straddle type injuries are known to cause bulbar urethral strictures more commonly, especially when a fall astride occurs. Now, what's the pathophysiology? What do we know? The previous speaker has mentioned that the normal urethra is lined by pseudostratified columnar epithelium. This epithelium, when it is bruised or injured, tends to repair by squamous metaplasia. Now, small tears in this metaplastic epithelium results in urinary extravasation. And it is this urinary extravasation that results in the fibrotic reaction that occurs within the spongiosum. To put it in clear terms, the etiology can be, like we've already mentioned, bacterial, chemical, trauma. What happens is there's a change in the epithelium. Fissures develop in this epithelium and there's extravasation. Now there's overexpression of connective tissues. Usually there's change in the collagen structures, usually from type 1 collagen to type 3 collagen with changes in the nitric oxide synthetase, metabolism. This results in fibrosis in the corpus spongiosum. As the fibrosis tends to get worse, it leads to loss of distensibility of the corpus spongiosum, and depending on the etiological subtype, fissures may begin to occur in the spongiosum with extravasation of contents into the space, resulting in more inflammatory reactions occurring. Of course, if this is circumferential, it worsens the stricture setup. Okay. Now, this is a diagram trying to show all I have said. This represents the urethra, the pseudostratified columnar epithelium, which usually you find in the bulbous and the pendulous urethra. In the membranous is transitional epithelium. Once there's an injury here, usually in the with the urothelium, this basal laminar layer tends to release its connective tissue products into here, into the lumen of the disc, and the narrowing tends to occur in a progressive way. Yes, the narrowing occurs first as a collar. As it gets worse, it involves the tissues, the surrounding tissues, and it can even extend beyond the corpus spongiosum into the surrounding structures. This can lead to the cracks, the watering can perineum, the perineal abscesses, and all the other complex things that happen with strictures. Now, the urethral stricture is characterized by changes in the extracellular matrix, as I've mentioned, and the normal connective tissue is replaced by dense fibers interspersed with fibroblasts. And of course, there's a decrease, as I mentioned, in the ratio of type 3 to type 1. This associated decrease in smooth muscle collagen causes the problems that are noted. One thing to note is, even when these inflammatory reactions are occurring, the patient may not present with symptoms until the lumen has narrowed to less than 10 French, when it starts presenting with other lower urinary tract symptoms, which the next speaker will most probably talk about. What did we conclude from all we have looked at and what I looked at? Trauma is still the most common cause of urethral strictures in our environment. Iatrogenic causes are on the rise. Iatrogenic causes are on the rise because of an improvement in our urological armamentarium as we catheterize more, which is the most common cause, and as endourology begins to improve, we are beginning to find more cases of iatrogenic causes of urethral strictures. Infections are still common, especially as we enter our own hinterlands. The etiopathogenesis is still evolving, and more importantly, one thing we know about the urethra is that it's this unforgiving. Prevention is always a key we should take note of. These are my references. Thank you very much.
Thank you very much, Dr. Chinedu. So we're also keeping to time. I think we have not lost much time. So the next is Dr. Isiaka Lawal from National Hospital to present on clinical evaluation and diagnosis of urethral stricture. Dr. Lawal. Okay. Dr. Lawal, you have 15 minutes.
Yeah, yeah. Good evening, senior colleagues and colleagues. Can you see my slides?
Yes.
Yes, yes.
Okay,
yes.
so I'll be talking about the diagnosis and evaluation of urethral stricture. Just briefly following this outline, the history examination, the imaging investigation, some of the other investigation differentials, and I will conclude. Urethral stricture most often present with insidious onset of lower urethral symptoms. And most of the time, these symptoms are usually predominantly obstructive, with associated spraying or splitting of the urinary stream. In most cases, they tend to progress, if untreated, to chronic urinary retention or acute on chronic urinary retention. In some patients, they may present for the first time with some of the complications that I've mentioned, and some that will be discussed later. And this may include things like periurethral abscess or perineal fistula when urinating, the typical watering can perineum. These are some of the cases we usually see in those days in neglected cases, but we see some of them in our environment. Suffice to mention that we have some cases of urinary stricture presented for the first time with uremia. So apparently, if it's left untreated. Now, urethral stricture following urethral cyst usually form within a year. but some of the symptoms may not be apparent until 10 to 20 years after. Whereas post-traumatic urethral stricture can be apparent as early as 6 weeks after trauma. So when you evaluate such patient, there is usually a predisposing factor if you take a very detailed history. And this may include a history of shoulder injury, for that post-traumatic, trauma from any cause, maybe fall, instrumentation, or catheterization, just like my last colleague talked about. In this environment, it's very common. Especially when we use some of these police catheter, tend to cause a lot of reaction in the urethra. There have been cases of failed hypospheric repair in childhood, presenting in adolescents or adults with very bad stricture. There may also be positive history of urethritis. In cases like that, you need to actually go deep because the patient may have forgotten that he had issue of poorly treated urethritis in the past. Previous surgical history, barely now that a lot of our colleagues a lot of our practice in the urology has improved. We're having some cases coming with urethral stricture following TURP or TURBT. But that's more, we see more of that in our center. Now, when the patient is examined, most of the time they're very stable, especially except when the patient is in distress from pain. For those coming with acute retention or acute or chronic retention, the significant finding on examination may just find a palpable bladder. For those that have chronic retention, when you examine the genitalia, it may reveal a palpable induration along the urethra. However, the absence of this induration does not exclude stricture because it actually depends on degree and at the time the patient is picked. An attempt to relieve the obstruction by catheterization actually is not possible despite adequate lubrication, even the best of hand. DRE may not reveal anything, but it's essential to exclude prostate enlargement. Also, for those presenting the context of a PFUD, there's a need to do a thorough neurological examination. So based on this examination, we can actually exclude the common differential, which in this environment could be BPH, which is very common. Of course, that tends to be common in the middle-aged and the elderly, whereas stricture, you can see it in younger people, especially if there's history of trauma, or there's previous history of urethritis. Others could include things like CA posterior stenosis or urethral tumor. Now, how do you evaluate these patients? Now, the essential investigation that is necessary in a patient with a suspected stricture include urethography, ultrasonography, MR urethography, and cystourethography. Urethography, that's retrograde urethography and MCUG remain the basic and the most important investigation in the evaluation of patients with urethral stricture. Usually, it identifies the site of the stricture, the length, the number, as well as whether the stricture is complete or partial. That's very important in determining the appropriate surgical model that be adopted for the patients. In addition, the MCUG highlights the proximal extent of the stricture, the presence or absence of the verticulum, therefore those that have long-standing stricture, or presence or absence of a reflux. It also gives an idea of the state of the bladder neck. This is very important in patients with PFUD. So when you do a combined RUG and MCUG, it's very important in patients with PFUD because you need that to be able to assess the gap between the proximal and distal end of the urethra, as well as the state of the bladder neck. This is a typical normal RUG showing this is actually part of the penile urethra. And you can see the junction here, the bulbopenile junction. This is the bulbar urethra. This is the distal, and on my right here is the membranous. Now this particular one is showing bulbar stricture. Now, this particular image, the stretching of the urethra is not adequate. So actually, they're supposed to pull on the urethra so that this is straightened out. What you are seeing here is just a normal, just an air bubble. But the main stricture is here. And looking at this is typical post-traumatic stricture. This kind of patient will actually benefit from excision and primary anastomosis, as my senior colleague will discuss later. Now, but this particular patient, this is also a bulbar urethral stricture, but you can see this is a longer stricture involving the mid and about distal penile urethra. This kind of patients will definitely benefit from substantial retroplasty, like buccal mucosa graft, as probably my senior colleague will discuss later. So RG is very, very important. Even with RG alone, you can know where the stricture is, you can know the extent of the stricture, you can actually decide what they're going to do. Now, when you have a patient with PFUD, you understand, a combined RG and MCG is very, very important, as you can see here. Now, so this is the RG component, and this is the defect. And this is showing the bladder and the bladder neck. This particular patient, now the bladder neck is open. This patient also has a fracture, which has been sorted out by the orthopedic surgeon before referring to us. Now, apart from the RG and MCUG, ultrasonography is also very, very important in the evaluation of patients with a urethral stricture. In fact, Jack McNich in 1988 described sonography as being more accurate in estimating stricture length than retrograde urethography. Sonography is a dynamic study. It is radiation-free, and it gives accurate stricture length, as well as the depth of the spongial fibrosis. Now, the problem with RG and MCUG is that you cannot actually determine the extent of that spongial fibrosis. Ultrasonography is not very common in this environment, but suffice to mention that some studies have been done to actually correlate this fact. Akpayak et al., for example, review about 60 patients where they try to correlate with the finding on RG. And they found out that ultrasound actually is very, very accurate. Now, a more detailed study was done by Oyelewo et al. In 2001, which they look at the finding on RG, the finding on ultrasonography, and also the finding on table. They tried to measure the length, and they found out that the ultrasonography is actually very, very, very accurate in estimating the length. So in addition to the fact that it doesn't give you the the depth of spongial fibrosis, which you cannot get from the RG and the MCUG. So it is being advocated now that in centers where you add the facility, it's always good to use as an adjunct evaluating your patient. The only limitation of the ultrasonography is the experience. Most of the time, it is operator dependent. So you need a very dedicated sonologist to be able to do that. And most of the time, you may not be able to apply it for patients with posterior urethral stenosis. This is a typical image of ultrasonography. You can see the stricture segments. And if you look, you can actually see the depth of the spongial fibrosis. Now, going forward, the other investigation is the color Doppler of the penis. This is very important in patients with PFUD, and it's done to measure the flow and velocity in cavernosa arteries pre and post property injection. Patients with PFUD may have androgenic insufficiency, which may lead to severe ED. And now, when it is bilateral, if you follow the anatomy that Dr. Ifyok mentioned earlier, you can lead to bulbar, apart from leading to the failure of your urethroplasty, it can lead to bulbar necrosis. So a long segment of the bulbar can be lost if this is not done. So it's been advocated now that patients that have this PFUD, if available, color Doppler. And it can also help, especially in patients with ED, because for medical reason, you need to prove that that patient probably had the ED, not from the surgical intervention, but rather from the injury ab initio. Now, apart from that, you also have, there's also need to do abdominal ultrasound, abdominopelvic ultrasound. This is needed to assess the blood pressure changes in the upper tract, like peribilateral adenosis. Now, this is very important because if a patient has stricture and already affecting the upper tract, in such a patient, you may actually want to divert the urine and allow you want to decompress the upper tract before you go and relieve the stricture. You can also see if there's any evidence of bladder stone, which tend to happen in some patients, or a diverticulum, which can also be sorted at the same sitting. Another imaging modality that is being advocated now is MRI. Now, the first series on MRI was also published by Professor Jack McNich in 1992. And he advocated that he was able to prove in that particular series that the MRI, particularly for patients with PFUD, is very, 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 very accurate in assessing the depth of that defect in patients with PFUD, especially for patients that require reduced surgery. Preoperative MRI can provide useful information that might help to determine the appropriate surgical repair for the following reason. One, it can correctly estimate the length of the defect, which you may not be able to see properly when you do your combined RUG and MCUG. It also indicates the type and degree of prostate displacement. Most of the time when you have PFUD, there's always displacement of the prostate. So you may not be able to see that displacement on your RUG and MC because that's just a 2D image. And also precisely delineate the site and density of the scar tissue. That's also very important because when you go there, I want to repair, for those that have been involved in doing the repair of PFUD, you must excise all that tissue completely now to prevent recurrence. I'm sure my chief will talk about that later, Professor Jani. It also reveals the presence of paraurethral force tract. In some patients with PFUD, especially those that will fail uretroplasty, it's possible that the bulbar urethra may have been anastomosis to the bladder rather than the proximal urethra. So when you do an MRI, this actually brings out this image. Now, if you look at this now, look at this particular image. This is the RUG and MCUG. You can see the defects. You can only see it in one way. You cannot actually assess that the depth and the displacement. But if you look here now, you can actually see it better. And if you look at this image below, so this is the beauty of the MRI. But the only problem with MRI is it's very expensive. There are very few centers that have it, and even when it's available, most of the patients may not be able to afford it. Hopefully, by the time more centers have it, probably the cost will come down. Another imaging technique that is being advocated is CT cystourethography. This is a 3D imaging modality, and the first series was described by Hector Sabi in 2003. Now, CT cystourethography, just like MRI, that's a very good outcome. You understand? But the problem with the CT, like most of us know, that is has a high radiation dose, and so there's all that risk of contrast allergy. So because of that, it may not be applicable for everybody, and it's very, very expensive. And of course, it's somewhat limited when you have patients with urethral, anti-urethral stricture. Uretroscopy is very, very important. It offers direct visualization of the urethral lumen. So you can actually see full-blown stricture. You can see stricture in evolution. You can see any urethral growth. For some patients with urethral tumor can actually present with features of urethral stricture. Also, it affords the opportunity to take a biopsy of any suspicious lesion, which may be responsible for the urethral obstruction. Antegrade scoping of the bladder neck can also be done, especially when you are going to do an PFUD. And most of the time, urethral can be done on table prior to uretroplasty. So it's very, very important. In fact, Dr. Sanjay, most of the time when he's doing uretroplasty, he always does cystoscopy and pass a guide wire so that it doesn't make it tract. The other joint investigation that may be necessary in a patient urethral stricture is the full blood count, lateral urine creatinine, and urea MCS. If there's any infection, that needs to be treated before you proceed with uretroplasty. Okay, these are the image of a cystoscopy for patient with urethral stricture. So you can see here, there's no full-blown stricture. So if you do an RUG, this particular patient, you may actually not see anything. You can see some stricture, you can see the irregularity of the mucosa. So you have some stricture in evolution. Now, this kind of patient now, if the kind of patient should go for TRP, there's a risk that within a short time, this stricture may progress rapidly to a full-blown stricture. So this is benefit of the cystoscopy. So in conclusion, detailed history, physical examination, imaging modalities are essential in establishing diagnosis of urethral stricture. Retrograde radiography remains a simple, affordable, and reproducible imaging modality for evaluation of patient with urethral stricture. However, newer imaging modalities like MRI and CT/CUG are associated with improved outcome in building PFUD repair. Thank you very much.
Thank you very much, Dr. Lawal, for giving us detailed clinical and imaging modalities for the evaluation of urethral stricture. Those that join later, please send your comments and questions to the host through the chat panel. The next presenter is Professor Habib Tijani, and he's going to talk on treatment and follow-up. Professor Tijani, okay. Share your slide and you're on.
Are my slides visible now? Visible?
Oh, no.
Not visible yet?
Yes, it is. It is visible now.
Okay,
it is now.
Okay. Good evening,
Professor Tijani, you have 25 minutes.
Okay, thank you very much. I'll try. Urethral stricture is quite extensive. So in 25 minutes, we won't be able to talk about everything. I'll probably be biased towards my own practice. First of all, what are the indications for treatment? It's not every patient that has urethral stricture that requires treatment. Indications include the presence of complications. If the patient has some of the complications that have been described earlier by the earlier presenters, the watery can perineum, the renal failures, hydronephrosis, and that's an indication for treatment. Presence of worrisome symptoms. Usually, most patients that have peak flow rates above 10 usually don't have severe symptoms. So generally, we also say when the peak flow rate is less than 10 mils per second, but again, this is mainly related to the symptoms. Now, what do? Before any definitive treatment of urethral stricture, one of the first principles is to divert the urine when there are complications. So whether it's with this patient already has acute urinary retention, has fistula, renal decompensation, you divert the urine first. Then you then think about the definitive treatment. So now definitive treatment includes what we call instrumentation. Instrumentation in this case, we're talking about the urethral dilatation using your bougie or the internal urethrotomy. Now, the key thing about instrumentation, that is both DVIU and dilatation, is that most times they are not curative, but they can be curative for short segment bulbar urethral stricture with minimal spongiofibrosis. So one indication is to cure, but usually for short segment bulbar strictures. It can also be palliative. You can also use it for short segment bulbar strictures that you think may not be amenable to, for whatever reason, you don't want to operate the patient, you don't want to have the patient urethroplasty, or the patient is just maybe too old or has some other comorbid factors. Now, when you want to decide on instrumentation, whether urethrotomy or dilatation, you can also, the location of the stricture also guides you. For meatal and fossa navigularis strictures, basically, the only option you have when you are talking about instrumentation is dilatation, because it's very difficult to navigate that scope when you want to deal with strictures of the fossa navigularis. Sphincter strictures, preference is also for dilatation for obvious reasons, because if you decide to offer such a patient urethrotomy, there is a higher risk of incontinence. Then easy strictures, you can also dilate. Difficult strictures that require guide wire, it's always better to use visual urethrotomy so that you don't go through a false passage. Now, urethrotomy, I don't want to go too much into this. There used to be the Otis urethrotomy, which is blind. I'm not sure anybody uses that anymore. Then there is of course, in practice, what most of us will use the visual urethrotomy or visual internal urethrotomy. Traditionally, the incision is made at 12 o'clock position, mainly so as to avoid injuries to the structures like the rectum. But there are some other, particularly experts like Tona Warwick, prefer the 4 and 8 o'clock incisions. But basically, the outcome is the same. It's really very effective for short segment bulbar urethral strictures. And then once you've done this, how long do you characterize? Some will say you characterize for 3 days. Some will say for 21 days or in between. Again, there is no consensus on this. Other forms of treatment include distal urethrotomy. It's basically not more different from this, not more effective than the coach using the same cold knife for urethrotomy. Stents. There was a time they were very popular. But basically, there was a time they were very popular, but basically, there's the popularity has significantly waned. And if you've ever had to operate a patient with urethral that has had a stent, it's usually very, very difficult. In intermittent catheterization, you can also offer that for motivated patients. A lot of patients, however, they will tell you that what they want from you is to cure their strictures, not for them to take care of their strictures. Now, the definitive treatment for most cases of urethral stricture is urethroplasty. And this basically, for most strictures anyway. Now, one of the principles when you are going to offer a patient urethroplasty is that you should, as much as possible, avoid urethral instrumentation close to this time. Okay, usually the principle is you leave, you don't tamper with the urethra at least 3 weeks before urethroplasty. Now, a brief history, surgical form of urethroplasty, there's no time. Traditionally, people simply just used to excise, leave the place open and allow epithelialization. One of the earliest one was Urethral. In Urethral will simply just excise the urethra and then will not tubularize and allow, and then use skin, cover with skin. This is a principle. This is a principle of Urethral and Johansen. They will open the urethra, cover with skin, and do not tubularize. They don't tubularize the urethra. They depend on the principle that epithelial surfaces, when left alone, will tubularize on its own. Johansen, this is only the same thing. Now, modern urethroplasty. The factors that determine what you do or your decisions will include the location, whether it's anterior or posterior, the length, the cause, the etiology, and then if there are underlying problems. First principle I've mentioned, divert urine when there are complications. Second principle is that excision and end-to-end anastomosis, or in some cases, non-transecting, that's applying to the bulbar urethral, for the bulbar anyway, urethroplasty should be performed when possible. The excision and end anastomosis has stood the test of time. The non-transecting bulbar urethroplasty, you can use it for bulbar urethral strictures with minimal spongial fibrosis. I will show some slides. However, the excision and end-to-end anastomosis, well, concerning the penile urethral strictures, the teaching used to be it's not feasible for penile urethral strictures, but that is absolutely not true. Some penile urethral strictures, some authors have challenged that, and I've also seen it from experience. That's penile urethral strictures, 1.5 cm, very short segment, complete penile urethral strictures where you need to absolutely transect. You can get away with 0.5 cm up to 1 cm. For bulbar urethral strictures, it is the common teaching is that if the stricture is more than 3 cm, you cannot use excision and end-to-end anastomosis. But there are many publications that have again contested this. I personally will not do excision and end-to-end anastomosis for bulbar urethral strictures more than 3 cm. Because generally, when you mobilize the bulb from the suspensory ligaments to the bulbomembranous junction, you will get at least 2 cm or 2.5 cm. Most times with excision and end-to-end anastomosis, success rate for post-traumatic cases approaches close to 100% if you follow the normal principle. This is a diagram. The principle in E and E, excision and end-to-end anastomosis, is always a 2 cm, minimum of a 2 cm spatulated anastomosis. In other words, you spatulate, you cut 2 cm off the incise by 2 cm the proximal end. Depending on your preference, this can be done, if you perform this dorsally, then this must be done ventrally. So 2 cm overlapping anastomosis, that is the principle, and you should be able to accept a catheter of a size 30 French gauge catheter. These are pictures of the non-transecting anastomosis. These are the pictures of the non-transecting anastomosis. Here, what's been done here is the urethra, the bulbar urethra has been rotated, and then the mucosa and part of the fibrotic corpus spongosus has been excised, but not the whole of the corpus spongosus. That is why this non-transecting is only applicable for those cases where the fibrosis is not extensive. So usually for a lot of post-traumatic strictures, fall astride, it may not be feasible. So this has been, so basically then this is what is next. You approximate the mucosa and then the remaining corpus spongiosum, and then if possible, you can now anastomose the other end, or you put a flap. You can put a flap or a graft. That's what has been done. Now, when excision and end-to-end anastomosis is not feasible, then substitution becomes inevitable. When you want to substitute, what can you use? You can use the graft. You can use the graft. Typically, we prefer to take the graft from the buccal mucosa or flaps, usually from the genital skin, preferably the penile flap. And then there is a tunica abugina uretroplasty. In tunica abugina uretroplasty, you are not really substituting, but it's similar. We'll get to it quickly. Now, when you are going to do a substitution, and only it's always better than a tubularized. So if you now must do a substitution uretroplasty, it is always better to do an only than to do a tubularized, where you now need to, when you do a tubularized, you end up having two anastomosis, poor support, and then there is always the risk of stricture. Then for the only, what do you prefer? Either it's dorsal, ventral, or lateral. In theory, the dorsal only is said to be better in terms of the less risk of diverticulum formation. I think I have the slide, yes. This is a ventral only. So in theory, there is a risk of diverticulum, whereas the ventral only, it's support, there's support by the crura. But there are studies that have also challenged this, and from experience also, I've seen very little cases of diverticulum arising from a ventral only. But the dorsal only, that's the principle, that's the reason given by those who advocate it. Then you can also use this. Also, this is still a ventral or dorsal only. How you mobilize the urethra, you rotate in size, put your flap, put your graft, and then you return the urethra to its position. Whenever tubularization becomes inevitable, then it is better for you to do, whenever it is inevitable, a multi-stage procedure rather than a single-stage procedure. There is always that strong temptation, particularly if you are involved, if you are dealing with patients with strictures, patients with post-hypospadias strictures and so on, there's always that temptation to want to put a tubularized flap. The reality is that when to put a tubularized flap as a single-stage procedure, the reality, however, is that it is far, far better for you to do a two-stage procedure than to raise a tubularized flap and then use it as a single-stage procedure. Of course, tubularized graft, that one is a no-brainer. You can't do that. But whenever you need to tubularize, it's always better to do a two-stage procedure. And of course, if you end up doing a single-stage procedure for whatever reason, and you must tubularize, and it's a single stage, then it's better to use a flap than to use a free graft. This is very common when you are doing hypospadias surgery. If skin is used, if you have decided to use skin, either for your flap or you have decided to use skin for your graft, penile skin is better because of the fact that it's a non-air bearing area. But we know now that the perineal skin, the scrotal skin can be made hairless by using some of these, there are a lot of these electrical depilatory agents that you can use. And the scrotal skin, you actually end up destroying the hair follicles of the skin that you want to use for your substitution. But generally, we prefer the penile skin. Now, penile urethra, I've mentioned this. Exchange to end anastomosis, 0.51 cm. Again, this is subject to opinion. Substitution for penile skin, if you want to do substitution, Orandi. Now, this is Orandi because it's unlike the bobber, it's so easy to raise your local flap. So in Orandi, you are making a longitudinal incision, you are raising your flap, a dartos flap, and then Yeah, this is still Orandi. You raise the flap and then it's like a flip flap. You open the urethra and then this is the flap you have raised. Then you open the urethra and then you just flip the flap back. So this is it. You just flip the flap back and then you close. This is Orandi. Popular, I don't do it. I prefer to use Jordan. Now in Jordan, what Jordan does, because the problem with Orandi here is that your anastomotic line will overlap. So there's a risk of fistula. In Jordan, similar to Dockett's, in Jordan, you deglove the penis. Raise your flap from wherever you want to raise your flap from. I always raise my flap from the dorsum to absolutely reduce the risk of fistula from necrosis, penile skin necrosis. In size, put your flap and then you close back. Now, the advantage of this when you close back is that your anastomotic side are not going to overlap. So it's very difficult for this kind of a patient to have a fistula. So if you are using a stage procedure, this is the buccal mucosa, very popular. Almost everybody does that. I don't think I need to go into details about the buccal mucosa. Now, fossa navicular strictures, uncommon, very uncommon. Basically, I see maybe 1 in 20, 30 cases. And the problem with fossa navicular strictures is that in majority of patients, you will be able to manage many of them by just simple dilatation. Urethrotomy doesn't work. I mean, it's not possible. Technically it's difficult. You can also just do a myotomy. But when you do a myotomy, you end up giving the patient a form of an acquired hypospadias. So one of the common techniques you see in the books is basically a DY plastic, where you just raise the skin from around the, if the individual has not been circumcised, you use from the prepuce, otherwise you take from the area around the skin around the corona after you've excised the stenotic segment. Now, the problem with this, the diagram, well, the problem with this is that for a lot of patients, they are still not satisfied with the cosmesis because of the fact that they have a scar along the ventral surface of their glands. So a modification of that technique was the penile cap urethroplasty. Penile cap urethroplasty, the flap is raised, or the initial flap was raised from the ventral surface, and then the glans was on the glans is undermined, and then you simply just anastomose your flap to the urethra. You can anastomose under. You can also tunnel this up and anastomose from outside the urethra itself. That is from the meatus. The problem with this also was that there was still a risk of fistula. Okay, this is what we do. I said my flaps are always from the dorsum. So when you raise the flap from the dorsum, you really don't have any problem with fistula. The danger when you raise your flap from the dorsum, of course, is that you can create penile torsion. So you can always avoid torsion by making your flap to be very long. Once it's long, then there shouldn't be a problem. Now, for bulbar urethral strictures, excision and external anastomosis is still the preferred option. For cases with minimal spongiofibrosis, then you can consider them for non-transecting urethroplasty. You can use the option, of course, when you need to use a substitution, is either you use the flap, the penile flap, or the buccal mucosa. The question here is that is the patch equally as good as the flap? Evidence indicates, or is the graft equally as good as the flap? Yes, evidence suggests that the outcome is the same. Of course, the buccal mucosa technically is easier, but you would prefer the flap in areas of uncontrolled infection, areas with poor vascularity, like post-radiation and so on. You will consider the flap rather than the buccal mucosa. The other things when the next presenter is probably going to talk about complications. So the advantages of using the penile flap, these are some of the advantages, particularly for patients that have not been circumcised. You can replace almost all the length of the urethra. Of course, flap necrosis, quite rare in good hands. Now, one of the problems of the genital skin flap, particularly if you're using the penis. Of course, is the scar around the corona. Patients in societies where they're circumcised, where they're not circumcised, it's an issue. But in West Africans, it's not really a problem. Other problem, penile necrosis, I'm sure the next presenter will talk about how to prevent these complications. But these are ways to prevent these complications. Buccal mucosa, the advantages are there. It's hairless, it's accustomed to being wet, and it's resistant. It's very useful in patients that have lichen sclerosis, because when patients have lichen sclerosis, you really can't use genital skin. Disadvantages, the presenter will talk about that. This is Quartet that was mentioned. In Quartet, the flap this is for bulbar urethra stricture, raise its flap from the ventral surface, penile degloved. In our own modification, we don't deglove the penis at all. We raise the flap from the dorsum and we just tunnel it down. That reduces the risk of so clinical uretroplasty. What do you do here? Basically, you simply just incise the urethra. This is the urethra. You've mobilized it. It's not amenable for excision and end-to-end anastomosis. It's in particularly the penile urethra. You simply just incise the urethra dorsally, and then you open the lumen, and then return it back to its position and switch out to the tunica albuginea. So it gives you, it's like a substitution, but you are not really mobilizing any tissue for it. I've only done it once. For whatever reason, it's not very popular, but those who advocate it advocate that it's almost as good as raising a flap or using other forms of substitution uretroplasty. But this is usually amenable mainly for penile urethral stricture. Although you can still try it for bulbar. Pelvic fracture urethral dysfunction defect, quickly before my time is up. Classically, it's not described as, it's not really a stricture, because in a stricture there is spongial fibrosis. In PFUDD, there is no loss of urethral tissue, but basically it's a distraction. Most cases of PFUDD will always manage by excision and end-to-end anastomosis. Almost, you can always manage. Occasionally, however, the defect can be very long, and that can make it very, very challenging. Now, for a typical stricture, 2 cm, 3 cm defect, by completely mobilizing the bulbar urethra from the suspensory ligament down to the membranous urethra, you'll be able to actually overcome that defect. Occasionally, it is not easy. It's not possible. So the first step you can take is to separate the crura. When you separate the crura, the urethra now, instead of urethra now lies in between the crura. And that basically, that can give you 2 cm. It gives you a 2 cm, at least a 2 cm defect. You can breach that. If that doesn't work, then you can also excise the pubic bone. And that also gives you another 2 cm. So you already have 6 cm. And then if that doesn't work, excise part of the excessive excision of the pubic bone, and you reroute the urethra. You reroute it under one of the crura. This is the urethra. You now reroute it. You've taken it, you reroute the urethra underneath the crura here. But you need to excise a lot of bone so that you don't have, okay, that is it, okay? So that you don't have a necrosis of the urethra. Usually by the time you do this, you are going to get at least 8 cm. And at least 8 cm. This is just a description of all we have done. Basically changing the course of the bulbar urethra. This is the normal course. So by trisecting this, by dividing in between, by rerouting, you shorten the course of the bulbar urethra. What are the reasons for failure? Most times, first of all, in reality, uretroplasty is not for the occasional reconstructive surgeon. Ideally, you should be doing at least 20 cm cases, 20 cases per year. And I always say, from my own experience, the greatest cause of failure is lack of adequate mucosa approximation. Mucosa, I always say, the mucosa, you must get the mucosa, particularly for the PFUDD. You must see the verumontanum so that you are very sure you are anastomosing the bulb to the prostatic urethra. Spatulation. the 2 cm overlap, the 2 cm spatulation, overlapping spatulation, it's so important. And and because every single time you do a urethroplasty, you must be aware that whatever your technique, there will be narrowing. Vascularity. So make sure that your tissues are well vascularized. This is a way to get the mucosa in PFUDD because it can be very difficult. Usually by straightening the needle, you can get the mucosa. So spatulation, always remember, and then your catheter, you have done a repair and it cannot comfortably accept a size 30 French gauge catheter, you are asking for trouble. Again, then, of course, you control the infection. If you are going to do a redo, don't do a shortcut. If you think you want to do a redo, start all over again. Bad tissue, excise bad tissue, and start. Counsel your patient that you may need to go 2 times or 3 times, but don't take a shortcut. I mentioned here that, okay, anyway, follow up. There's no consensus to follow up. It's basically patient-specific. What is important is patient-specific history. You look at the symptom score, uroflowmetry, uretrogram, endoscopy, abdominal scan for post-void urine. These are all ways you can follow up the patient. But again, there is no consensus. You will have to individualize the individual patient. Again, can anesthesia to end anastomosis be bettered? Yes, particularly, well, those who have advocated the non-transecting anastomosis for bulbar urethral strictures with minimal fibrosis, they claim it's as good as this or even better because at least you preserve the blood supply. We are waiting for, hopefully we'll get the off-shelf graft where you want to do urethroplasty, you can just pick a graft as you do in vascular surgery to replace the urethra. Of course, there should be guidelines. Now, by now should have its own guidelines for the management of urethral stricture. Then I mentioned something about last man standing. Almost every aspect of urological practice is being taken over by robotics. But I think it's going to be a long time before the robots take over urethroplasty. Female urethral strictures, I think, also wide. Most strictures in females we're going to manage by dilatation because the urethra is very short. But occasionally, you need to do a substitution. And if the strictures affect the bladder neck, we'll have to consider permanent urinary diversion. These are my references. I've tried to keep to time, and I think I overshot the time by some few minutes. Thank you very much.
Thank you very much, Professor Tijani. Yes, it is difficult to discuss treatment and follow-up in 25 minutes, but you have really tried and gave a very good overview. So the next presenter and the last one, not the least, complications of treatment to be taken by Associate Prof. Usman Taylor.
Okay.
Dr. Taylor,
yes.
Share your slide and go ahead.
Tijani, please stop sharing.
Okay, I should start?
No, Tijani, first of all, stop sharing.
Tijani should stop. Yeah. Prof. Tijani to stop sharing.
Yes.
Sorry.
Okay.
So.
All right, Dr. Taylor.
Okay, sir.
Share your slide.
Yes.
You have 15 minutes.
Yes, sir. You can see it now?
Yes, we can.
Okay. So I stand on the existing protocol. Good evening, everybody. I will be presenting on complications of urethral stricture management. I will follow this brief outline starting from introduction, list of complications related to urethral stricture treatment, which includes complication in conservative management, complications from endoluminal treatment options, complications from urethroplasty. Then I will make comment on individual complications, risk factors, and the management aspect. Then I conclude. By introduction, as in any other procedure, urethral stricture management also presents with its own complications. The goal is to try and prevent it. And when it occurs, then early diagnosis and intervention is advised, either medically, surgically, or both. So many studies were done in our locality, including to the international ones, related to urethral stricture disease. Studies by Ahaji, Dakum, Oranusi, Ekeke have all captured, etc., have captured complication aspects of their experience in the managing of urethral stricture. But unfortunately, barely few or absent paper that was titled Complication of Urethral Stricture. Most of them are on management. Then in the process of discussion, the complications are being mentioned, but no single paper to my notice in our locality that was dedicated and titled as Complication of Urethral Stricture. We need to be bold to share our experience in terms of challenges so that people can learn from it. I want to start with the complication of suprapubic cystostomy. SPC is done either as a temporary or a permanent measure. As a permanent treatment for some patients with urethral stricture, especially patients that have very sick, that cannot withstand major surgeries, or patients with radiation-induced strictures, very difficult strictures to manage. So SPC may be the only thing you can do in such patients. Now, there are complications related to SPC, starting from surgical site infection. The common risk of developing surgical site infection in SPC is the prolonged SPC wound dressing or poor catheter toileting. This looks very simple, but it's a common practice. Sometimes without our notice, patients will feel that with the dressing, if it is not applied forever on their own, as if they will have herniation of bowel or something like that, false belief. So that continuous dressing of the SPC site actually causes emaceration of the site and excoriation, sometimes very dirty looking. Then the culture of catheter toileting. So what we do in such patients is to culture the wound, swab, and also do urine MCS, and then treat them appropriately with antibiotic. Then the other complication is perivesical fluid collection. This is mostly common in trainees where multiple punctures was done to do SPC. Or in a situation where the catheter balloon is sited out in the perivesical space. Definitely, there may be collection of urine in the perivesical space in such patients. And ultrasound scan will help to confirm the location of the balloon. These patients may require recatheterization or may even require redo SPC. Retained catheter, another complication related to SPC. Prolonged indwelling catheters are at risk of developing retained catheter. And one culture of practicing urethral catheterization, we use sablon or normal saline to inflate the balloon. You know, the price for that is that during the course of deflating, you will face some challenges. From the sablon, the bulb, the foam actually will not allow you, or in the normal saline, the sodium chloride aspect will crystallize and then we may obliterate the lumen and give difficulty in deflating the catheter. So these are some of these challenges that can happen with patients with SPC. And ultrasound scan will clarify the catheter balloon location. Then from a step ladder pattern, the deflation can be tried if it did not work by passing the bulb to aspirate on the catheter or directly or ultimately, if it did not work, ultrasound-guided puncture of the catheter balloon. Other complications, dislodgement of the catheter can happen in patients with SPC, either as permanent or awaiting ultimate definitive management of the stricture. Recurrent bladder spasm is another troublesome complaint we get from our patients, which is a common problem. And one of the resource persons have actually published a paper on the role of anticholinergics in patients that are on catheters. It gives them a lot of relief by giving tolterodine, which reduces the bladder spasm in patients on indwelling catheters. Stone formation is another complication. Now, complications of endoluminal treatment. Complication of endoluminal treatment of urethral stricture, I wish to start with balloon dilatation or balloon dilation of the urethra. One of them is excessive bleeding. This actually occurs when there is overstretching of the site of the stricture by the catheter balloon. When the balloon is overinflated, then stretching, tearing of the mucosa, and followed by excessive bleeding. This is what happens. So the balloon capacity and the fluid that are used for inflating at the side of stricture should have to be done with caution. Best way is image guided or visual guided rather than doing blindly. Extravasation may follow after urethral injury during balloon dilatation, false passage, rectal injury, and even false passage, yes, and even rectal injury can occur. Unfortunately, few of such cases are done here in our locality, in our region. So in Nigeria, I'm yet to see a paper that was written on balloon dilatation, but this one was published in Endourology Journal. Then the management in such patient is just pass urethral catheter if possible, or do SPC to divert urine. This may suffice. And in a situation whereby the dilatation was not succeeded, then one have to plan to come back again for either repeating the dilatation or in an upward manner for a better option of managing the short segment stricture, which includes either anastomotic urethroplasty or other better options. Now, complication of DBIU. In DBIU, complications are mostly observed in the hand of trainees with insufficient skills. This includes extravasation of irrigation fluid or urine with subsequent infection. Overzealous incision made by a trainee or an unexperienced may result in incision deep into the corpus spongiosum, and this may result in severe bleeding. And at the time of the bleeding, advisable one should stop another incision, because when you make another incision blindly, you are likely to injure more urethra and more corpus spongiosum and more bleeding. So this can happen. This may result in even edema with urethral perforation, as earlier mentioned, and urethral fistula later. Diverticulum may occur following DBIU. Others include injury to the corpora cavernosa. This one usually happens when the incisions is done in a multiple places, not only at 12 o'clock, but at 8 and 4 o'clock, corpora cavernosa, and even corpora cavernosa can be injured. Injury to striated external sphincter is another common presentation. So therefore, the verum montanum has to be used as a guide in order to avoid this ultimate complication. Then erectile dysfunction can as well happen as a complication of DBIU. Complication of DBIU have been observed to be about 6.5% when using cold knife, as compared to 11.8% when using hot knife. Here, Jean et al. report that using cold knife, you have a lesser complication than using hot knife. Probably, you know, when you are using the hot knife, you are likely to have more hemostasis as you are coagulating. You may be tempting to make deeper incision and likely to have more and likely to have more injuries into surrounding tissue. A comparison was also made between laser and cold knife and found that using cold knife for DBIU has higher rate of complications, predominantly bleeding, as compared to using laser. Now, this is in EAU guidelines, and some of these complications that I've earlier mentioned are also listed here. Urinary extravasation, incontinence, retention, almost similar. There is no much statistical significant difference between these two using the cold knife or the laser. Permit me to proceed because of the time. Now, locally in Nigeria, one of the studies that was done listing complications during DBIU, which are similar to earlier ones mentioned in the table above, but additionally, those missing one that observed in that study was epididymoorchitis, which we see not only in DBIU, even you can notice that even in prostatectomy patients on catheters, we also observe this. The other observation made was scrotal gangrene. That's one of the complications following DBIU. These are some of our peculiar or unique type of complication we see in our localities. Some of our patients, after having problem after DBI being discharged, may refuse to come back on time. So when they present with a serious complication, and therefore they may present with scrotal gangrene, not that under the watch of the surgeon, but actually some patients may refuse to return, come to follow up when they have problems until when the problem becomes very serious. Now, generally, what do you do in such patients with complications from DBIU? Initially, you target conservative management, divert urine, either urethral catheterization or SPC, then antibiotics and analgesics. Such patients, if at the first attempt, they had this complication, but you are able to create channel for urine passage, it may be the ultimate curative treatment for such patients, or you may have to come back for another session of DBIU or a better option, like anastomotic urethroplasty. Complication of urethroplasty. In urethroplasty, as the earlier speaker, my senior colleague, discussed, which will be difficult for me to go take each one of them to discuss within this short period, but this complication of urethroplasty determines by the type of urethroplasty, the experience of the surgeon about that technique. If a surgeon is experienced about using penile flap and he has never used skin graft or buccal mucosal graft, he needs to do it jointly with an experienced person so that from there he can pick and able to perfect. So the technique, very important, peri-operative preparation and care of the patient. I am emphasizing on this number 3 because many complications arise because of rushing to do urethroplasty. We ignore basic urine MCS, treat the patient, repeat the MCS, and then ultimately treat.
Dr. Taylor, let me interject. The time is off, but use another 1 minute to summarize this.
Thank you. Thank you very much, sir. So generally, complications include in such urethroplasty patient hemorrhage, wound infection, flap necrosis, recurrent stricture. Recurrent strictures can be avoided or can be reduced to BRS minimum when we prepare our patients very well. Another complication is hairball. We have seen this, a patient that developed hairball following urethroplasty. In this patient, actually, patient came with perineum was already shaped, and the area that thought to have
hair was thought not to have hair, but actually there is a hairy hair, and after urethroplasty, he developed hair growth. So other complication in our locality here, but by this auto, ureterocutaneous fistula and recurrent stricture are the top leading. Complications by Daku metal are also outlined here. Recurrent stricture, wound infection, similar to the previous ones. Complications also internationally, this was published by Santucci et al. In terms of minor and major complications and so forth and so on. So in conclusion, complication will stay with us for a long time, as long as we continue to manage urethral stricture. Our elders said, if a surgeon have not yet had complication urethroplasty, it means that he has not done enough. All of us in this platform, unfortunately or unintentionally, have contributed in one way or the other to the world statistics of complication of urethral stricture. Our focus should be on how to manage it. Our focus should be on how to manage it and manage it professionally by preventing the occurrence and early diagnosis and management in case it occurred, so as to reduce the morbidities. So finally, my statement is that we should be patient to prepare our patients very well before we proceed to give treatment for urethral stricture. And our target at first instance should be aimed at curing the patient, if possible, not rushing to do and then later lamenting to start repeating, because the more you repeat the treatment of stricture, the lower the success rate occurs. Thank you very much.
Thank you very much, Dr. Taylor, for true talk. Thank you. I think we have all done justice to these topics. Well done, everybody. We now go to the next aspect. We have just a minute to round up, but let's take discussions, questions and answers. And Prof. Ekeke will lead us. You have the
Stella, please stop sharing your
question bank.
Okay, sir.
Okay, so the first question here is from it said, Lawal, the image you projected as stricture is evolution seems more like normal concertina of the urethra. Lawal.
Actually, it is not. Hello, sir, can you hear me, sir?
Yes.
No, it is not. In the normal concertina, you see that irregularity, but it does not compromise the lumen. But when you have stricture and evolution, there's some compromise of the lumen. And in fact, if you are doing a rigid scope, the first thing you even notice apart from that is that the ease at which your scope goes is less. That particular image I projected actually enlarged it. So that's why the thing looks like that. If it was reduced for that, it would have been the Ame would have appreciated it better. There's always that difference. In the stricture, there's some compromise.
Okay, to Professor Tijane, what catheter size do you use to stent the urethra post urethroplasty? Tijane.
Okay, generally for the adults, I use the reason why the individual asked the question was because I said the lumen must accept the size 30.
French.
Hello? Hello, am I audible?
Yes, go ahead.
Yes, sir.
Hello, you are continuing.
Hello.
We can hear you. Go ahead.
Am I audible now?
Are you inside the car?
Hello.
Park your car now. Tijani, we can hear you. Park.
I can't hear any. Okay, fine. Yeah,
Maybe it's his network.
No, it's not. No, he's in the car. He's driving off. I think he should have parked and finished this presentation before. And most of the questions are to him. Okay, let me read the question. Any other person can make comments.
Okay. All right. Okay. I think, yes, go ahead.
Okay. So you say, what option do you have surgically to surgically manage a patient with complete acquired urethral destruction, anterior and posterior, or complete division of bulbar urethra into mid. No, I've missed the question, sorry. Okay, let's start with this. What size of catheter do you use to stent? So anybody can answer.
Yeah, okay, I don't know whether I can comment, sir.
Yes.
Yeah, go ahead.
I think the teaching is that the smaller the catheter size, the better. I think Professor Mundi, most of the advocates use either 14 or 16 when you are doing the posterior uretroplasty. But anything more than 16, actually the risk is more of putting pressure on your site of anastomosis. I think Professor Tijani was just mentioning that 30 French to tell you about the ease of your, to tell you about the adequacy of your spatulation. Does not mean that you're going to stent over a 30 French. 14 French or 16 French. 14 French if you are doing posterior, 16 French if you are doing anterior, and preferably a silicone catheter.
Okay. When do you say a patient is scared? When do you say a patient is scared? Okay,
Professor Rami wants to respond. He's ready his hand.
Okay, let me unmute him. Okay, Professor Rami, can you unmute yourself?
Okay, can you hear me?
Yes, go ahead.
Yes.
Go ahead. No, you've muted yourself again.
Hello?
Yes, go ahead. No, you have us. Unmute yourself. Yes, go ahead.
Okay, it automatically mutes again. Okay. I think I made the comment when you said about the calibration with 30 French size. Can you hear me?
Yes.
I don't know for whatever, if any one of us calibrate a urethra to 30 size for any reason. Even when you are going to do QRP.
You need to speak louder, sir.
I said I don't know how many of us would. I don't know how many of us will calibrate. Can you hear me now?
Yes, go ahead.
Ramil, I think. Can you hear me?
Yes, we can hear you.
Okay, I say how many of us calibrate the urethra to size 30 for any procedure, whether it's TR or whatever, and then more so for urethroplasty, that we calibrate to 30 before to be sure that the caliber is adequate. Does anyone calibrate for any reason?
If I may commit,
I know you are
comment. I think we normally calibrate to
26. Mommy is back.
I think it is
28. So you give a gap of at least 2 centimeters or two French size, so that you don't bruise the urethra. But to calibrate with 30 intra-op for urethroplasty is what I don't understand. Whether that does not,
I think,
in itself overstretch the rest of the urethra.
Prof. Ramil, I think I agree with you. It's adequate to calibrate 26 to 28.
My comment is clear.
Yeah. Prof. Ramil, I think it is adequate to calibrate 26 to 28, and most people stop at 28.
Yeah.
Is it?
Yeah, I think so. I can hear you.
That is. Yes, it's adequate to calibrate 26, 28. Most people stop at 28. There's no need to go to, in most cases. Well, maybe that is the practice, but I think for most, 28, 26 is adequate.
Yeah, because if you calibrate to 30, they're still going to put a size 16 or 18, or not even 18, size 14 or 16 to do anastomosis. So why do we need 30?
Pass a comment, please?
Can
I pass a comment, please? Can I pass a comment?
Yes.
Okay. Hello?
Go ahead.
The calibration has nothing to do with the size of catheter you are living in. It is simply to take care of possible stenosis after your repair. the wider the lumen, the wider the area of your anastomosing. But that's what I was saying in my presentation. It's not the size of the urethra. The area where you are doing your anastomosis itself should accept and should be as wide as possible, because of the fact that all urethroplasties, there will be stenosis at your anastomotic site. Yes, so that's just it. That's nothing to do with whether you are going to leave a size 16, size 12, or size 14. We're talking about the anastomotic site. And if the bottom line, anybody who is covered with urethroplasty knows that the wider that area where you've done your anastomosis, the better your chances of a long-term cure. That's what I said.
I think, yes, yeah, Prof. Tijani, I think it's clear, it's very clear. It's not because of the insertion of the 14, 16, but it is the need to have wide urethra for anastomosis.
Yes.
Because it will always it will narrow. I think it is
yes,
clear.
That's the reason.
So it is okay. Let's go to the next question. Prof. Keke. Prof. Keke.
The next question. How would you approach a patient with multiple skip strictures with an island of normal caliber urethra?
Okay, I'm sure that question is for me.
Yes.
Yes, it is.
Basically, you'll take it as the way you manage a long segment urethral stricture. That's what I would do. Those normal island will probably not play any significant role in your management. You have to take it as a long segment urethral stricture and then decide on what you are going to do for such a long segment urethral stricture, whether you are going to put a graft, a flap, or whatever. But that's the way I'm going to manage. Manage as a long segment urethral stricture.
Yes, Prof. Tijani, I agree completely with you. Because once there are multiple lesions, you must assume that the urethra is diseased. And if you just take care of the narrow part, you come back. So you have to treat it like a long stricture. I agree with that.
Okay, as a follow-up to that, in managing patients with long segment stricture with persistent positive urine culture, how do you approach that?
Well, I'm not sure that question is very clear. If the patient has persistent or
if there is persistent positive urine culture, which means there's infection, and yet there is long segment stricture, how do you approach it?
Well, you're going to manage it the same way you want to manage a long segment stricture, looking at all the parameters. Would this patient qualify for a substitution? Would this patient qualify for even instrumentation, ureterotomy, dilatation? The bottom line is that whether there is an infection, I mean, if the patient has infection, recurrent infection, then you have to manage the stricture. So for me personally, if someone has recurrent infection, long segment stricture, I'll most likely, except on rare occasions, I'll most likely consider that patient for urethroplasty. But the less invasive options can always be tried for such patients.
So, Prof. Tijani, what type of, I think they're asking of also the type of, tissue you will use. Is it flap? Is it graft? If you have to take that risk.
Take a risk. Generally, I'm a proponent of flap, the penile percutaneous flap, but I've also occasionally used the buccal mucosa before. Again, when you look at the publications, the success rate are said to be the same. So the key thing is really do whatever you are comfortable with, and then manage it as a long-term. So if you are a buccal mucosa person, or you're more comfortable with it, you use it. If you are more comfortable with the penile flap, you use it. But if the long segment stricture is in the penile urethra, it's far better to use a local penile flap. But if it's in a bulbar, the buccal mucosa will probably have a stronger edge.
Yeah, I think since there is question of persistent infection, a flap should probably...
The persistent,
because
the persistent infection, in this case, one will assume is from the obstruction.
So would you not want to divert the urine?
Yeah, that is it.
Oh, of course, the basic principles are there. We're talking about definitive treatment, the basic principles of diversion and so on. Yes, but the definitive treatment is when you talk about persistent infection, except you are talking about infections like watery camperineum. But if you're talking about UTI, I don't think it makes a difference whether you are using a flap or a buccal mucosa. But if you're talking about infection like, yes, perineal infection, fistula, and so on, which you have been unable to effectively control with your diversion, then I will tend towards a flap. So I think maybe the infection needs to be clarified. If it's perineal. So, but of course, you divert first.
I think, Prof. Tijani, you have explained it well with your last statement. Thank you. Let's go to the next.
Okay, I have a comment on that, sir.
Okay.
Sorry, okay, Prof. For bulbar stricture and penile stricture, yes. So I think there's still a room for buccal mucosa. First, the Sanjay Kukanis technique, which has been popularized and found to have very good results. Okay, what? No, Prof was saying that if you have penile stricture, that flap is better than if you have bulbar.
No. Maybe no. We are talking of this infected. You know, we have persistent infection like fistulae.
No, when the infection, when the infection has been treated, and you have a patient with bulbar stricture.
Hello?
No, if it's treated, then once the infection is treated, it's another thing.
No, what Prof said was that when the issue of infection has been treated, if you have penile, that it will prefer flap. If you have bulbar, it will prefer buccal mucosa.
Oh, okay.
That was the last statement he made. So I'm not saying that, yes, I agree with you, sir, but I'm aware that with the new Kukanis technique, when you have even both, when you have both penile and bulbar, even upon urethral stricture, it's been found out that buccal mucosa is very, very good. In fact, when I was in center, some of the cases we assisted him in he had very good results. And what it does in such a case is that you don't completely elevate the urethra from you don't detach it from the corpus. You do a one-sided dissection. So the vascularity is still somehow preserved. And the outcome is very good. In fact, he doesn't believe so much in flap. But like you said, it depends on the
outcome is.
Okay.
Yes, quite correct. The outcome is good with buccal mucosa also. And if it is long, you can use double buccal mucosa from both cheeks and then apply. So you are correct. Thank you.
Okay. Is there any room for combined approach, abdominal and perineal, for posterior urethroplasty? Any room for combined approach?
Yeah, as a matter of fact, if you look at the slides, there were so many things I excluded during my presentation because of time, but a lot of those things were covered in the slides. Yes, but I can tell you from experience is that I've only had to do an abdominal perineal approach twice. Most cases of PFUDD with long segment distraction, if you follow those steps, you will almost always be able to assess the bladder neck, because the major reasons why people will talk about using an abdominal approach or a combined approach is usually because of the difficulty in getting access to the bladder neck. But most times, if you can, you will be able to get access if you follow those first stepwise that step ladder approach. But when it's not possible, yes, you may have to actually now go abdominally, transect the pubic bone around the pubic symphysis, and then you do your anastomosis. Usually in that case, you may need to do the anastomosis intra-abdominally after mobilizing the bulbar urethra into the abdomen.
Professor Amir.
Come.
Hello?
Yes, Professor Amir raised his hand.
So bad.
Professor Amir. Yes.
Prof. Ekeke.
Yes.
We are running out of time. So how many more minutes will you want to give? I also want to make a brief comment before we close.
Let's see if we can take more questions, then you make a comment.
All right.
Okay. All right. How would you manage a patient with a complete acquired urethral destruction, anterior and posterior, or complete congenital urethral dysplasia stroke absence?
Tijani?
Yes.
Please, can you repeat the question, please?
What options do you have to surgically
Can you repeat the question?
Yes. what options do you have to surgically manage a patient with complete acquired urethral?
Complete urethral destruction. Okay.
Or anterior and posterior, okay, or complete congenital urethral dysplasia or absence?
I think the reality is that the principle, I will assume that when you talk about complete urethral destruction or absence, it's talking about the penile bulbar, okay? And we see this a lot. Basically, this is what you do when you repair hypospadias. Typical hypospadias patient, you said that you don't have adequate anterior urethra, adequate penile urethra, you don't have even bulbar urethra for the perineal hypospadias. So basically, you still have to harvest near urethra. You have to harvest either the buccal mucosa, or if the individual has not been circumcised, you use the prepuce. But traditionally, or basically, for you to have good success, you probably need to do it two-staged. And of course, you are going to tubularize. But it's basically the principle in hypospadial surgery, because those patients really don't have their urethra complete.
Okay, what size of needle, what specific sutures do you use? Needle size, shape, and suture type for PFUD?
Well, if you are lucky, if you have the J needle, you can use the J needle. That usually makes approximation of the prostatic mucosa easier for you. But if you don't have it, what I do is to bend. I unbend the needle to give me a sort of a J. Typically, I use 4O for adults. I use 4O Vicryl. Of course, for children, you use something smaller. For hypospadias, I always use monocryl if it's available. Otherwise, I use Vicryl. For adults.
When do you say a patient is cured for urethra?
It's difficult, but to some extent, you can probably, for urethral stricture, you can only probably talk about it, because we know that strictures, most strictures, when they reoccur after urethroplasty, you find them in 6 months, within 6 months. But you can actually talk about cure for the average post-traumatic stricture. Then let's look at a typical fall astride stricture. Such short segment, complete stricture, where you have excised the stenotic segment, you have done your well spatulation. That is, the area of your spatulation is very wide, and the patient has been asymptomatic. You followed the principle and you've followed up for a significant period of time. You may think about cure, but when it comes to stricture, anybody who's experienced with stricture will never want to talk about cure. But in practice, some of those patients, we end up discharging them. Once they are those, they don't have symptoms.
Okay, final question.
Before the next question, Prof. Tijani, I've seen many reports on that for anastomotic, when a patient is not having recurrence after 5 years, it's considered cured. And for substitution after 15 years, what do you think?
Okay, what I don't know about substitution, I mentioned just before you cut me short, I also mentioned 5 years. That actually for a typical, I use fall astride strictures as a classical example. If you've done your good anastomosis, patient is asymptomatic, your follow-up is okay, 5 years, you can talk about cure. But anybody who is experienced with urethral stricture repair knows that you will still see occasional patients that were said to have been cured.
Yes,
particularly for substitutions. Yes, particularly for substitutions. I've seen patients 10 years, 15 years, 20 years coming back with recurrence. So it's difficult. But one should just shouldn't get too cocky with outcomes.
Maybe the last question. What is the landmark for division of bulbar urethra into mid, proximal, and distal bulbar in RUCG? What is the landmark for division? I think it goes to the investigation person, Lawa. What is the landmark for division of bulbar urethra into mid, proximal, and distal bulbar in RUG?
Okay, that bony prominence at usually that is scalar tuberosity that usually the urethra hits against when there's fall stride. That region is the mid-bulbar. Between that region and the bubble membrane and the external sphincter is the proximal bulbar. Then between that region and the bubble penile junction is the distal bulbar. So they actually the proximal third, the mid third, and the distal third. So that bone is actually the important landmark.
Okay, moderator, over to you.
Thank you very much, everybody, for this wonderful session. My light just went off, so I'm trying to augment.
You can see you.
Yes, okay, thank you very much. So I just want to add a few comments. This time is up, so I'll be very brief. I wanted to ask Dr. Lowell the role of uroflowmetry, if any, in the evaluation and even follow-up of urethral stricture. For ureterectomy, in addition to just performing ureterectomy, now we know that, you know, the urologists, now surgeons add some other measures to reduce the recurrence, such as mucosal injection of steroids, such as triamcinolone and even COX-2. It has been shown now to reduce the recurrence following ureterectomy. And for instrumentation, Prof. Tijani said 3 weeks. Yes, 3 weeks should elapse before considering urethroplasty, but I think it's rather short. Prefer, and most reconstructive surgeons will wait longer, some up to 3 months, 6 weeks to 3 months after instrumentation. And so because urethra actually tends to settle better and your outcome is better if you allow that period of rest. So for fossa navicularis strictures, I think the Kulkarni method has simplified fossa navicularis management of fossa navicularis. I'm sure Dr. Lowell must have seen it with long strictures. Yeah. Starting from meatus down. When you make a dorsal ureterectomy, generous dorsal ureterectomy on the fossa navicularis, you can use actually oral mucosa, and you have very good results. And to reduce complications of erectile dysfunction, damage to bulbar arteries, and risk of necrosis, bulbar necrosis, etc., we now know, in addition to non-transecting urethroplasty, other measures such as muscle sparing, nerve sparing, and even vessel sparing, where you try to retract, if you don't have to go down, retract the bulbar artery or preserve the bulbospongiosus muscle, that will reduce the rate of complication following urethroplasty. And I think we also consider tissue engineering in the management of these strictures when you have minimal amount of tissue and you need a large area to supplement, or you have to come several times. Oral mucosa is being engineered, and I think this discussion is really, maybe we need another discussion on from this forum. Maybe we need another discussion on surgical management of strictures, urethroplasty, etc., because there are many questions and there are many unanswered. But so far, I think it has been a very good and am I off?
No, you are on.
So we all need to manage strictures. We all know, whether you are in reconstruction or we are not. All urologists, from the time you see your patients, etiology, we have seen, they need to prevent strictures. And if you don't manage these strictures, we are creating more strictures and more complications. So I hand over to Prof. Okeke. Thank you very much for inviting me and for asking me to moderate this session. Thank you very much.
Okay, before the chairman of our CME, Professor JJ is raising his hand. So please, Professor JJ, unmute yourself. Okay, you've unmuted, so you can go ahead.
Thank you for joining us today. We can't see your face.
Okay, can you see my face now?
Well fed.
Yes,
Partially.
Well,
Very well fed.
Uh-huh.
well
Well
fed.
Lagos space.
Lagos space.
Let me talk on behalf of the silent majority that has been listening for the past 2 hours. I think on behalf of the silent majority, I'd like to thank each and everyone that has contributed to this fantastic debate. There's no doubt that urethral stricture is a problem in our environment. And I will say categorically, from the beginning, all of us has done very well in the various presentation. And it's obvious to me, like Tijani mentioned, that we have a lot of us who will be the last man standing because we have no choice than to use our skill and dexterity in managing all these patients. So at least we know for sure that no matter what happens to artificial intelligence or to robots, there'll still be a work for the reconstructive surgeons. And I'm quite happy, and I thank the chairman of the NAU's Educational Committee for keeping the flag going. And I hope that this definitely will rub off on our residents. And I think we should continue. I think it will be the benefit of our residents, our trainees. And I think the next level now is to how we can then rotate these residents to see a lot of this thing practically. For my friend in Sokoto, to my friends in Inewi, to those in Jos, and to a few of us in Lagos. On behalf, again, like I said, on behalf of the silent majority, and on behalf of the Faculty of Surgery, National Postgraduate Medical College, I thank you guys for doing a wonderful job. Please keep it up. Thank you. Thank you. Chairman.
Thank you very much, sir. That comment was very, very encouraging. Thank you, sir. So far this year, we have had erectile dysfunction twice, hypospadias, renal malignancy, male infertility with a talk on, we had a talk, okay, during the erectile dysfunction, we talked about female sexual dysfunction, and now urethral stricture. I think before the exam, we still have a number of things we have not done, but the committee will meet during the week and tell us what we do. For example, we haven't done BPH, we haven't done cancer of the prostate, and some other things. So during the week, I shall be giving information once I meet with the committee on what we are going to do next. Thank you very much for coming. We had, the last count I saw was about 129 people on this session. I hope a lot of them were residents. Thank you for coming, and God bless you. Till next month.
Okay, thank you very much. Please remember to send your abstracts to us, Port Harcourt City, Garden City 2022. We are waiting for your abstracts.
What's our theme again?
Urology practice in challenging economy. No, not COVID. Depressed economy. Depressed economy. Challenges of urology practice in depressed economy.
Economy.
Yes. Then the second, the sub themes are, one is urological intervention in renal disease. And then the second sub theme is urology, I can't figure it out, but urological training in Nigeria. So we expect your abstracts. We have sent the first call for abstracts. By the end of the month, you will show you the website and all that so that you start sending the abstracts. Thank you very much.
Thank you.
Thank you.
Thank you very much, everybody.
Thank you, everyone.
Thank you.
Thank you.
Yeah.
Marhaban is Ethiopia.
Thank you, sir.
So your greeting there now is Assalamu alaikum.
Assalamu alaikum.
Okay.
I hope you know how to answer.
Professor Wanfo, you want to greet us? Let me allow Professor Wanfo. I've unmuted you. I've asked you to unmute yourself, Professor Wanfo.
Yes, so Paul.
Aha.
Go
ahead, sir.
It's been a very interesting session.
Yes,
I
sir.
was listening very keenly, and I think they all did very good job. I thank you all.
Thank you, sir.
The slide, please.
Thank you.
Thank you. Yeah.